So I'm going to go to the next panel, what to expect from the self-test tool implementation in real life. So I'm going to invite Elena Ivanova, who is the
She's based in Geneva, Switzerland, and her work focused on emerging diagnostic technologies that has a potential to transform patient care in low and medium income countries. She has led research and development work in the fields of tuberculosis and hepatitis C diagnostics. She led groundwork in exploring potential of self-testing for hepatitis C screening, and since 2021, expanded her activities to self-testing for COVID. Elena is coordinating several projects at FIND on self-testing, spanning from early research to development work through product launch and demand creation. Elena, the floor is yours. Thanks a lot for keeping up so late for us. We do appreciate. Thank you.
Thank you so much. Thank you for this kind introduction, Carlos, and thank you so much for giving an opportunity to talk about our some of our past experiences and evidence that we have acquired in self-testing, as well as the some ongoing plans. Do you see my slide deck in the presentation mode?
Yes, perfect.
Okay, great. Yeah, so we have started the work around self-testing for COVID-19. We started more than 1 year ago. So it was started to conceptualize actually late 2020, and then kicked off some things in early 2021. And we initially structured the work around the three main pillars, which are technology development, because we right from the start knew that there is a great need, that we cannot do much without an affordable and high performant self-test devices. The policy development, so generate the evidence that would allow would support to the development of the relevant guidance, international and national, and market shaping. So all kind of activities around demand creation, and then piloting the introduction of the products in different settings in the countries. So I will talk very briefly about the upstream product development activities, and then more on the downstream product implementation parts. But briefly, so I've mentioned already during the first session that we've secured commitments from 4 manufacturers that are listed here on the affordable preferential pricing for low and middle income countries. So again, just to underline, this is the export price, meaning this is the price from the factory. It doesn't include the distribution margin, it doesn't include shipment costs and any relevant taxes. So the end price would be bigger than that. But also want to highlight that it's a maximum, it's a ceiling price. So meaning that if the volume are higher, or there is any special arrangement that can be made with the company, this prices could be and should be negotiated, and the discounted prices are very much possible. We also secured the volume commitment just to make sure that in case of spiking the demand spikes in high income countries where the company usually makes more money, that it doesn't, supplying this market doesn't come at the expense of the LMIC market. So there is a minimal supply commitment. So apart from the 4 tests, the 4 manufacturers that are listed here, there are 2 more that we cannot yet disclose the names because the contracts are not yet signed, but we'll be able to do it very soon. And then so you'll see that professional use versions of this test are mostly having the different kind of international approvals, and then some of the self-tests has received already some stringent regulatory approvals as well. So just to mention that the next step for us would be that we will be doing the evaluation, evaluation of clinical performance of this test, and we'll be publishing the results of that on our website. So on the implementation experiences. So some of the early work that we've done last year, it was a groundwork on to understand the values and preferences around self-testing. So it specifically in low and middle income countries was well before the implementation of the self-test. The only exception is India, where the self-test was already implemented. But in most of the other countries, it was still a theoretical exercise when people were asked, were administered the multiple choice questionnaire, and then asked about which was asking about their perceptions and views and willingness to test. And then also a qualitative part when a subset of participants were invited for more in-depth interviews. In total, was more than 6,000 individuals included in the survey in general population across these 8 countries, and Brazil is one of them. And then we also asked healthcare workers about their opinions. There was more than 2,500 of healthcare workers across all the studies. So the results, there is a lot of data that we have collected through this research, but the key results I'm showing you here that first of all, we've seen a high willingness to use the self-test. The majority of people said that they are likely or very likely to use the self-test. And then the most importantly, when we asked people what would they self-isolate if the result was positive, the also absolute majority said yes. It's not here, but also we have asked whether they will report the positive result to the healthcare authorities if there is a channel for this reporting existing, and also more than 90% said yes. It was a bit less for negative results, so it's reflects that people think that it's much more important to report positives and perhaps less important to report negative results. Some specific data from Brazil. So it's those that I've just showed before. It was pooled data from all the countries. So in Brazil, we have the study was conducted, the survey was conducted in São Paulo, and the willingness to use was a little bit less than in other countries at that time, and it's probably because there was still a lot of hesitancy around the performance and then potential usefulness of the self-test. Just keep in mind, this was before the self-tests were implemented in widely in any of the low and middle income countries, and the policy was not existing in Brazil at the time. But however, it was the answers to the question whether people would self-isolate after the positive result was consistent with what we've seen in other countries, with a majority of people saying that they will. So people will do the right thing after receiving the positive results. Just very quickly on the willingness to pay. So in the data that we've received in Brazil, when asking people how much would they be willing to pay for the test, it was the answers ranged from 0, so only will use it if the test is free, up to $6 per test. Very quickly on some key insights from the qualitative part. So there's a lot of there was quite a number of comments highlighting that the access to self-testing should be equitable, and then the test should be quality assured, and then the should be widely available in the range of outlets and in the range of settings, including non-health related distribution paths, such as convenience stores, kiosks, small shops, community organizations. So it was really highly valued by the participants. Guidance and support is very important. Also, participants have responded that there should be a very clear guidance on the next steps after the testing, but also an extensive education materials that would be building advancing the awareness about COVID and when to test for COVID, why to test for COVID, etc. So that was for the values and preferences survey. Another project that we've collaborated with our partners in Malawi and Zimbabwe with last year was the study to evaluate the feasibility and acceptability of the self-test in both rural and urban population. So it was what we looked at in frames of this study was how easy can people understand the instructions for use translated to a local language? What's and collecting their comments, what was easy to understand, what was difficult, what was which message is very straightforward and which is very confusing. So we've also observed people while they were doing the testing and collecting information about the mistakes and errors that they've done during the self-testing process. And also there was a qualitative part when selected subset of the participants have asked to provide some more in-depth views on the self-testing. The high-level conclusions are that the self-testing was highly acceptable, and the participants in both rural and urban communities in both countries can do self-testing correctly. It was a lot. Also, we've heard same comments that from the previous study that it should be the rollout of the self-test should be coupled with the a very clear communication materials and a very clear message. Just to show you some data, so that's the usability, the percent of the people who didn't make any mistakes in any critical steps of the testing process. Just to clarify, even like a slightest mistake which doesn't necessarily affect the test results would count as a mistake here, but the majority of the participants have done the testing, all the testing steps without any mistake. But then although there was some people who did some mistakes, it didn't really reflect on the performance of the test. So the concordance between the results of the professional use test and the self-test was extremely high, was 98% plus. We've seen no difference between the different age groups, and then we've seen no difference between the rural and urban population. Both populations have done the self-testing equally successful. We've seen some dependency on the age. So the elder the participant is, the more the probability of the mistake is. So that's another study that we've conducted over the last year. And now more on the studies that are in preparation and about to kick off this year. So this we've together with Untitled has launched a call to grant to award the different organizations to conduct implementation research that would cover actually testing and treatment. And some of the organizations that have applied and were selected for the award had a significant self-testing component in their work. So those are the PSI-led consortium that many of you, I'm sure, know about from their HIV work, HIV STAR. There is a KNCV Orum consortium. There are colleagues from Fiotech, which I'm sure everybody here knows very well, and the partners from IS Global. So the most of the beginning of the year, the partners were planning and working on the protocols and the study concepts, and then we do hope that the most of these projects will start in this quarter, and we will looking forward to get the exciting results by the end of this year. So just to give a bit of a sense of where the projects are placed and what are the research objectives. So they are in South Africa, Malawi, Nigeria, Zimbabwe, Uganda, India, Ethiopia, Ghana, Mozambique, and Philippines. So it's a lot of countries all around the world, and it's different types of research, but basically most of them are focused on how to optimize the self-testing service delivery models. They target different populations, sex workers, workplaces, healthcare workers. It's both symptomatic testing of the symptomatic individuals as well as serial testing of asymptomatic individuals. So it's really different models, different populations. And we'll get a lot of very exciting data on how the delivery of the self-testing could be optimized. And I'm sure that this data could be very much useful for transferable to the similar settings in other countries, and would allow to scale up the self-testing in the most relevant settings. I'm looking forward to hear from our colleagues from PATH and Fiotech more about their work planned in Brazil, so I'll not speak more about this. And then rather I will just mention some separate set of activities that FIND is leading through a parallel project. So we've focused the implementation research in 3 countries: the country of Georgia in Eastern Europe, Malaysia in Southeast Asia, and we hope to also to do several projects in Brazil. So Georgia is our most advanced country, where we already are very confident with what the target population would be. And we heard from the local stakeholders where the priorities lies. Malaysia, we're still in discussion, but we'll be we hope to have some clarity soon. And then we did have a lot of very useful discussion in Brazil, and many thanks to our partners here who really facilitated a lot of interactions and collected a lot of relevant information for us, but still looking forward to continued involvement and discussion, because we do want to hear your thoughts on what should we focus on here. So we are still in the planning phase, so it's really a right time to discuss further, and we really look forward to that. Basically, yeah, I can skip this slide, but go to the really the approach. So we started with doing some landscape research, and meaning that doing some desk research, understanding the status, the current status of the policy, and some whatever published information was, and then moved to interviews with some key opinion leaders in the country, and then where we're currently in is to identify the target user segment populations, target user segments where we would which would be the most which would benefit the most from the self-testing. That's what where we are at, trying to define which, together with the partners in Brazil, what are this target population. Once that is defined, we will move to the formative research, and that's really important. This is really when you are getting a lot of community insights of how the self-testing service delivery should be established and set up in this community. This is extremely important to get the feedback from the people who would use the test, and that to ensure that the model that you are conceptualizing and designing is actually something that is useful, is convenient, and is safe, and is acceptable for the people who would use that. And once this formative research stage is done, that will be ready with the implementation pilots, hopefully in Q3 this year, and will that would allow us to gather the data about how to operationalize the self-testing, how to make it the most cost-effective, and how to establish that as a sustainable intervention. I think I've covered that, and then that's what I wanted to share today. Thank you so much. Would be very happy to answer any questions within this webinar or outside, so please do feel free to reach to me or my colleagues, and happy to continue the discussion. Thank you.
Thanks a lot, Elena. It was great. I think you brought a very fantastic insight in order to give us clarity on the ways to go, and always having in mind that we are going beyond COVID. Self-testing can be an interesting tool, and I think you have shown that we do have a good journey to follow and bring the best possible result. If you don't mind, I would like to call Emily Gerf-Guyet and Délio Pereira also for the next presentation. And any questions to Elena, please, you can type at the Q&A. And at the end, if she's still available, then we can have some answers. Emily is public health researcher in the diagnostic group at PATH, working on diagnostic performance and operational research studies, primarily in malaria and other infectious diseases. And Délio is clinical director and researcher at CBDL here in Brazil. Please, Emily, you have the floor. Thanks a lot for keeping up so late as well. Thank you.
Yes, thank you. Thank you very much. And actually, today we're going to present a little bit about 2 studies, one completed and one that's what we're currently planning, both in collaboration with CPEM under Delio's leadership. So I'll actually pass to you, Delio, first to present on the diagnostic study we completed last year.
Okay, thank you, Emily. Thank you, Carlos, for the opportunity to present this first results of the study, and later on the partnership with PEF that will be the next project. So the first one, okay, yes, is here was we call it COVID DX. This assessment of viability of point of care testing for SARS-CoV-2 in asymptomatic individuals. We have a partnership with some institution here in Brazil, that's CPEM, Fiocruz, FMT in Manaus, University of Washington, Global Health Strategies at PEF, and Rockefeller Foundation in Amazon. This study was conducted between July 6th and September 29th, 2021. Was a prospective a diagnostic accuracy study was conducted in Porto Velho, Brazil, in collaboration with the Centro de Pesquisa em Medicina Tropical de Rondônia. It's that's called CPEM. It's in Rondônia State. It's the base Amazonia Basin. These studies aim to evaluate the performance of diagnostic tests for SARS-CoV-2, designed to enable point of care or decentralized testing approaches, also enable a greater understanding of trade-offs in testing selection to inform screening strategies regarding the timing and frequency of the testing and performance characteristics. So we do have here, let's see if I can, no, that's okay, I can move here. Okay. Okay. This study was a prospective diagnostic accuracy study was conducted among close contacts of COVID-19 positive cases in Brazil. 3 rapid antigen tests and 1 molecular method were evaluated against reference for RT-PCR on nasopharyngeal swabs. 2 anterior nair swabs, that are nasal ones, nasopharyngeal swabs, and saliva were collected at all visits. Vaccination history and symptoms were assessed. Household contacts were followed longitudinally. In total, 50 index cases in 214 contacts. Among those, 64 households were enrolled. 65 contacts were RT-PCR positive during at least 1 visit. Overall sensitivity of evaluate tests ranged from 33% to 76%. Performance was higher among symptomatic cases and cases with CT below 34, and lower among oligo or asymptomatic cases. The 2 rapid nasal antigen test, the standard Q nasal and the Lumira DX, demonstrated comparable performance, which was best among cases with CT below 34, with sensitivities in the range of 90% and 60% for symptomatic and asymptomatic cases, respectively. So this last slide for this study shows the time to positivity from time of first visit for close contacts with a positive nasopharyngeal RT-PCR results with CTs below 34 at any time. To help you, that the blue line is the proportion of nasopharyngeal RT-PCR positive case identified as positive by the point of care antigen test, the standard Q COVID-19 antigen test on nasal samples. The green line, those identified by the reference nasopharyngeal RT-PCR. call attention for the three boxes on the right that show interesting results that even with a relatively rapid test, RT-PCR results turnaround of 24 hours, more than 70% of the contacts would have been identified by the point of care test. At 48 hours, accumulative sensitivity is 80% and increasingly near to 90% at 4 days. This is important because the turnaround for PCR in most of places is not around 24 hours, it's more like 48 or later on. So the point of care test for antigenous one, this brings a lot of information earlier than the PCR. So the next slide, I pass it to Emily.
Thank you so much, Delio. Yeah, so building on that study and having the opportunity to continue working in Portobello, we started thinking early on about how this contact tracing platform that was established could potentially be sustained, or continue thinking about ways to use it beyond the close of the study. And at the same time, we started thinking about the questions of self-testing use cases, as they were moving through the relevant policy and regulatory processes in Brazil. And I think one thing that was really coming to the front of these conversations was that self-tests were available in Brazil, but through this pharmacy system and at a price that might be difficult for everyone to have equitable access. So the thinking was to really try and integrate self-tests into a public health system in a way that showed how they can be used, which really aligns with the overall aims of the STAR project that Elena mentioned earlier, which is just really looking at the operational system delivery strategies for self-tests, and what are those delivery strategies that can maximize the benefits that we've all been talking about and minimize some of the unintended consequences, which have been highlighted by other speakers. So the following slides, I'll just walk through the follow-on study that we have planned for later this year, where we're really trying to show if and how these self-tests can be integrated into a contact tracing system. So we're going to be testing the effectiveness of a serial self-testing strategy. So testing up to once per day for up to 10 days, and how that can support the public health contact tracing program in actually identifying positive cases. So our theory of change is that we can actually reduce the burden on the health system, on patients, and on providers, and get more testing data per potentially exposed individual. In this study, we'll use antigen rapid tests that have been approved for self-testing by Anvisa, and we'll be giving self-tests to both the close contacts of confirmed positive cases, and we'll be monitoring their use of the tests through remote data collection. So the objectives of the study are really wide-ranging. The primary of which is actually to evaluate the effectiveness of this service delivery method, looking ultimately at how many additional positive cases can we identify in the group that does self-testing as compared to the group that does more traditional contact tracing with either just testing at one point in time or potentially no testing at all. We'll be looking at a number of measures of the operational feasibility of self-testing, including the usability of the tests, looking at the concordance of a supervised self-test that's conducted at enrollment as compared to a professional antigen use test that's done by a trained health worker, again, at the enrollment visit. We'll be including some qualitative methods as well to explore the barriers and facilitators at both the provider and patient levels that may impact the success of this intervention. And then we will also be looking to generate supportive resources, much like the digital tools that were spoken about and some of the other user-friendly instructions for use, to include either that are test specific or maybe test agnostic, that will support self-testing and implementation. We also have a few more exploratory aims. We'll be enrolling close contacts through a positive index case. And so we're going to follow those index cases as well remotely to understand how they're adhering to public health guidance for isolation over the course of the study. As that changes, I think we've already seen it change and reduce the number of days in Brazil and in other geographies. One of the things we were really interested in was looking at more like voluntary at will use of the tests, sort of without someone having to be consented and enrolled into a research study, which the primary context for the study certainly will be. So we're going to reserve an additional subset of tests to give to the household members of study participants who can use the test at will and report data in an anonymized fashion. As I mentioned, one of the objectives was around these supportive resources. So to generate those, we'll be conducting usability workshops, which look at how the training and instructions for self-test can be optimized for our target population. And then to just sort of help us triangulate self-reported behaviors against a second measure for participants who consent. We will be looking at GPS data to help triangulate how they report their isolation and quarantine behaviors against what that data shows. And then this is finally just the study overview diagram to show kind of how we intend to look at these three distinct populations. So, our primary participants of interest will be the primary exposures, the close contacts of confirmed positives, and they'll be enrolled into one of two arms, the first of which will be more similar to traditional contact tracing, where they just get a single test at one point in time, the sort of municipality standard. And in the second arm, participants will be enrolled to receive, to first complete a self-test under supervision with a healthcare worker, and then next to take self-test home with them and to conduct them over the next 10 days. And then, as I mentioned, we'll be looking also at the index cases and at a bit more of a distance, what people who are given tests but not formally enrolled into a clinical study, what they would do with the self-test if given them. Okay, next slide. Yeah, so what do we hope to show or achieve with this study? I think primarily to understand if this is a viable strategy for integrating the use of self-tests into a public health service delivery program. And, we're hopeful that this could be a testing strategy that worked in both periods of high and low transmission. So I think, as the waves of the pandemic have come and gone, we've seen a huge establishment of testing services, and then they'll shrink when cases go down, and then they're needed again when tests come up. So, one of our hypotheses is that this could be a way to maintain one method of test availability without those big infrastructure changes. I think we're going to look closely at what operational guidance is needed for municipal health systems to actually implement this intervention, including what to do around the results reporting. And then finally, it'll be another piece of evidence that shows how tests, the performance of self-tests compared to the approved professional use antigen test at one point in time. And yeah, that's it. I'd be happy to answer any questions, comments, either now or offline. Thank you very much.
Fantastic, Emily. Please count on our support locally for whatever is needed for this kind of study. CBDL, Aladiv, and our partners locally. It's going to be a pleasure to support and evolve with this kind of investigations for future use of even other kinds of self-test. I think it's quite important what you're doing. I would like to ask you both if you can remain a little bit more, and then invite Thais Aranha from Fiotech to have her presentation, and then we open for questions and discussions after that. Would that be okay for you? Yes?
Sure.
Thank you.
Ok. A Thais Aranha Rossi é professora da Universidade do Estado da Bahia, UNEB.
Thais Aranha Rosa, she works with the Bahia University, the Federal University in Bahia. She has her doctorate in Sun European for sociology and political sciences in Paris, and she's a permanent teacher in UNEB. Thais, welcome. You are welcome to start your presentation. Thank you so much, Carlos. Let me start sharing my screen. Firstly, I would like to thank you for the invitation. Thank you for the organization. Congratulations for this event. I would like to present a control and, well, what we are working with in the protocol phase. This highest protocol, which is on the strategies for testing, quarantine, e-health, telemonitoring, and how it can contribute to the fight against COVID-19 pandemic in two Brazilian capitals, Salvador and Rio de Janeiro. And they actually have a lot of institutions that are participating in this project. The Federal University of Brazil, Fiocruz with the Infectiology Center, UNEP, the State of Bahia University, and the postgrad programs, and also the Federal University of Rio de Janeiro, but also the participation of the Health Secretariat of Salvador, Rio de Janeiro, the World Health Organization, FIND, and Fiotech itself, and Unit Aid. This protocol that I'm talking about has components that I'm not going to specifically talk about because our focus today is the self-test, but it's important to mention that this bigger project has a central component of implementing testing, self-isolation, self-test, and the second component related to comparing performance of two rapid tests, two antigen rapid tests to detect SARS-CoV-2, and also another component related to new variants of virus SARS-CoV-2. And this is a component that I'm going to mention here related to acceptability and usability of self-tests for COVID-19. It is important to mention that this study is coordinated by Dr. Inês Dourado, Dr. Vadilea Gonçalves, Dr. Vadilea from Infcruz, and as co-PIs, Professor Laio Magno, who is here with us. I'm also co-PI, and other researchers, Marcos Benedetti as project manager, Dr. Beatriz, and other investigators as well that contributed to this investigation. The goal of the project is to assess the acceptability and usability of COVID-19 self-testing among people from high social vulnerability communities in Brazil. And they are covered by the family health structure that I mentioned in both capitals, Salvador and Rio de Janeiro. In Salvador, in one sanitary district, and in Rio de Janeiro. It is a cross-sectional study that will be conducted on the population I mentioned from these two highly vulnerable cities, following inclusion criteria of individuals aged 18 years or older, and they will be recruited from both communities mentioned in component 1. So this is a protocol that has other components, and component 1 that we call TQT in Portuguese, there are some subcomponents that are related other than testing with the antigen rapid test, isolation, quarantine, and telemonitoring with vigilance, support to the work process, and monitoring this entire process that is being created, active searching, procurement for this test, including managers, staff for the secretariats of these cities. A digital platform that integrates the system, articulates vigilance, and gets a legacy that goes beyond COVID. We are looking for learnings. The included participants will need to be literate because they need to be able to read in Portuguese. It will be a purposeful sampling with 240 individuals, and they were selected because we want to have big diversity of the Brazilian population. So color of skin, minimal 50% having Black people, gender, age groups as well, young, old, and elderly population are included. Participants will be invited to participate in the research by a team that is trained in research, by community agents that work with health, considering that this study also wants to support the Brazilian public health system by professionals who are already working on primary care. And before the self-test, these participants went through an interview. They went through an interview by the researchers with a questionnaire about social demographic data, previous experience with COVID testing, and COVID itself, and also acceptability of self-test. After that, these researchers will, in another room, observe the performance of the participant related to the self-test performance, and they will record it on a specific form with a specific script to follow. So they will receive a self-test kit with the manufacturer, with all the information that comes with it, and there will be no interference in this process. So a trained researcher will observe and record the entire process for all the steps, registering if there were mistakes, confusion, what were the challenges, what were their mistakes, with no interference in the process.
There will also be a presentation for this participant of the devices, of the negative, positive samples that were reactive, weak, and valid. And then after 15 minutes, they will interpret their own results. And we have the duration of this study. The expected time is for 3 months. With quantitative instruments, as I've mentioned, have different social and demographic information, experience with the COVID-19 testing, and qualitative, and trying to find the register of these researchers for all the process that's being done regarding the self-test. And we will have dimensions related to the prepare for the test, the collect of the nasal sample, the performance regarding the test, the interpretation of the result, and also the general observation regarding the process of the test. And these instruments and the consent forms will be applied by a trained research team before the beginning of the entire process of this study and for the questionnaire. And what is the step that we are now? We have the local approval, the Fiocruz approval. We are waiting from the approval, the ERC from WHO, so we can move on with the data production, data analysis, the scientific publication, the technical production. That's trying to have a language that can support the decision making of the local managers, the national managers, and from other countries too. So we expect to contribute to increase the access to the diagnosis of COVID-19, to reduce to contribute with the reduction of the spread of SARS-CoV-2, the knowledge on usability about the COVID-19 self-testing, and also provide evidence for the decision-making, as I have mentioned, for the self-testing for COVID-19. And also we highlight the importance of the study about being a population of communities with high social vulnerability in these big cities of Brazil, Salvador and Rio, with a population that has a lot of times, the majority of them cannot buy this self-test. So we highlight the social impact of the study regarding this and communities that that are in high social vulnerability. This is what we want to talk about. I'm available here if you need to ask questions. Thank you very much. Great, Thais. I think that was your presentation was quite important to show what we can bring as conclusions and also be prepared for a next pandemic in a faster and more dynamic way. I would like to invite Elena, Pamela, who else? Rosana and Claudio, Mariana, for you to open your webcams. And if you want to make comments about the presentations, and we can go to the final questions and final presentations and maybe your conclusions or final remarks. I know that all of us, we have a lot of things to say, to share, and I thank you all for participating. Claudio, please. First of all, congratulations. Thank you for inviting me, and we comment about this, and this was in a lot of the presentations, that we are going through a shift in the paradigm, the technological point of view in the healthcare with more autonomy for people. We're talking about a specific case here about COVID, but I think that's a huge set of diseases and follow-ups that should be present in our future. The image of a different way of people to relate to that, to the service and the health service and the relationship between the health services. And Rosana mentioned about the challenges, about the production, because we can have other pandemics, and the needs to have production lines that are more flexible, that can easily change the type of agent that's being used, especially when you have more experience of fast tests that are not the self-tests, but quick tests in the approach about other syndromes when we have streptococcus and some other respiratory virus. And this can help a lot, not only for that health professional that are in the health service, but people in an autonomous way when they have good information. And we have something important here that's not being explored enough by the public health service, and the access to support services. Maybe you should think in a new service model that's the integrated service as a support with the self-test. I mentioned before, I think that not about the cost, but the price that it goes to people. It's a relevant topic. Even think that this price can go lower. I think that's hard to have we need to have an expansion of these technologies if the government doesn't participate with public systems to provide that, at least for the situations that are a priority and for those people that are a priority. So thank you, congratulations to everyone. I really enjoyed the presentations. Great comments, Claudio Delio, please. And I think that we should bring the point about the studies that we are working with, studies related to the point of care, the self-test, as we have seen. And in the world, we have seen other technologies, molecular technologies as a self-testing. United States have launched some, and also the information technology related to other solutions. So Delio, if you could, Thais, Emily, and Lena, to comment a little bit about this. The focus now in big volumes, low cost, accessibility, but without the other parts that are going to be more accessible. I will talk in Portuguese. What we have learned a lot with COVID is the dynamic of a new disease, and it's changing the technology for diagnosis, policies, the organization of the public health and public policies and treatment. This is quite dynamic and really fast. And what the majority of people are talking here is the important role of bringing awareness for the population, for the health system and the policies or the people that will decide about the laws. More than talking only about marketing and mention the quality, the goals, the usability of a self-test or antigen or molecular or something that will come. Maybe it's more about the branding to say what is the value of that for people to understand how important is this to be an instrument of daily use for epidemiological health system. And today we have discussions in Brazil talking about the end of the pandemic is not something that not one country will decide, but if it's endemic, if it's a pandemic, when it's going to change. We don't have important numbers yet as a control diagram to define how it's going to behave, if we have an outburst or not. So there are a lot of information that's missing. And this is going to impact of how much is going to be produced, what is the policy that's going to be organized as in sectors as a model. Is it going to be as influenza that we had outbreaks and it's there for a while, and then we have inputs for a period of time? Are we going to invest in vaccine or in tests? Because we are talking about similar syndromes, so tests that will be developed together. The importance that we didn't go deep on that about choosing the treatment. We talked about the previous treatment about medicine that we couldn't work with that, but we have new drugs that will work as it happens with influenza, that we have a window to start a treatment, an antiviral medicine, so for 48 hours. So the early diagnosis with antigen or point of care, it's quite important for that. And another topic is the access to that regarding the cost and the distribution of that. Sometimes in rich countries that they can buy that or the population can buy that. But the logistic to take this material and how to have access to what later, the treatment, the isolation, a lot of things needs to be learned. I congratulate to all the groups involved here that we have field works, we have investments on that to make the decisions based on evidence. I think this is my final remarks. I'd like to thank you all for the opportunity for listening to all of you.
Elena, would you like to make any comment? I am really very sorry to keep you so late, and it's my fault, I promise. On the 7th, we are going to have in Brazilian morning, so it's going to be easier. But I owe you one, so please feel free, from all my gratitude, feel free to make any comment.
No problem at all. I really enjoyed the meeting, and I really don't mind to stay late for a good cause. Yeah, no, I was. I feel it was a lot of very useful discussions, and there is. It does seem to me that there is. We do have a very useful guidance from WHO now. It is And as WHO colleagues have outlined, this is now to the countries to understand how to better use it and how to better implement that. And this is some of the things perhaps could be, you could model, or you could imagine, or you could calculate, and you can say, well, based on my theoretical assumption, this or this does not work. But then some of the things you need to go and then and try and go back and redesign and try, and it's worth it, because it makes the intervention sustainable. So you don't do something that is not workable. And honestly, this is what we've seen in high-income countries, where the self-testing was implemented more or less in the panic mode when it was on the rise of the epidemic waves, and so it was a lot of decisions were taken, and we have the means in terms of budget, so we have to respond to the pandemic in the fastest way, and there was a lot of lessons learned there, how to that would allow us, that actually going through that mistakes allow us now to think how to make it better. Now when we can be more cold-minded and more have a more common sense and planning in hands, and then use the self-testing not in a panic mode but more in a smart way. And that is, at least from my perspective, is also targeting those population that would benefit the most, and those who perhaps would not be tested otherwise, right? And I'm sure it is context specific, and it might be different from country to country, but it's paramount to identify what are the priority populations and how to make the self-testing easy tool for them to use. And then last but not the least, how to make sure it's not just, we are not going and trying things that would not be taking, that would not have funding afterwards, right? So we've talked a bit about the private and public sector, but if you make self-testing accessible only in private sector, I don't think you solve this equity problem, right? So it still would be a tool for rich and middle class people, would be accessible to those in need. So figuring out right from the start the ways of how to make it sustainable, at least for some selected population, securing international and domestic funding, for me, that is one of the most important aspects. Thank you.
Perfeito. Thais, por favor.
Thais, please. I will done the final remarks. I would like to thank you for inviting me, to thank the organization of the event, everyone, and what we have asked about the research in a dynamic moment that's the pandemic, and we are going through this perspective to study something that's happening, that's dynamic, and trying to create evidence that we can use to make decisions. So I think this is what we're trying to do. So again, I'd like to thank you for the opportunity, and I'm here.
Excellent. Great.
Final points. And Rosanna, you are the best one to make very nice conclusions. So be our guest here.
Thank you, Carlos. It's been such a rich range of discussions. I really thank you, for designing the program so that we could hear. Because even though I participated in the development of the WHO guidance, hearing how complex it is to translate the guidance into country guidelines and strategies is very useful, because every country has its own limitations in terms of resources, where are the needs, etc. And I especially when we were developing the guidelines about workplace testing, and we said it should not be coercive. And yet I know in many countries where if you're a healthcare worker, especially if you're a part-time health worker and who test positive and had not, don't cannot come to work, then you lose your wages, and who's going to support your family, right? In a lot of countries, they have wage subsidy. If you lost your job due to COVID, you are reimbursed for your salary so that you could continue to support your family. But in many countries, that's not the case. And so I think, you know, translating WHO's guidance to say, okay, no coercive workplace testing, that's a difficult thing for a lot of countries. And then other issues in terms of vulnerability, getting to marginalized populations, making sure that the access is equitable is also a real problem. But I think beyond that, we need to think of what we're doing as being very useful for the next pandemic. Heaven forbid there should be a next pandemic, but there may be. And we know that epidemics are happening more frequently and with more severity. So there will be pandemics. And so even as we are struggling to figure out for, say, the next flu pandemic, what should we do? We've never advocated for individuals to get flu testing because there is no time to intervene. Flu just comes in, it's very efficient, and goes through the population very quickly. So that's why we always say the strategy for flu is not testing, is to say, if you think you have the symptoms of flu, stay home so that you don't infect anybody else. But now would we say, if you think you have flu, go get tests, go get a self-test and see whether you really have flu or not, and stay home if you have flu. So especially if you're a healthcare worker or you work at care home, maybe this is what we need to say. And so these things need to be worked out, and whatever we're doing here would be very useful to inform that kind of future policy for the next pandemic, next epidemic. And then in terms of what Claudia said about, you know, other syndromes like respiratory infections in general, we should think about self-testing in sort of a broader aspects of it. But then beyond respiratory infections, I'm thinking of the self-test that we always wanted to prevent the risk of antimicrobial resistance, which is the simple rapid test to distinguish between bacterial and viral infections when somebody has flu symptoms or respiratory symptoms, because we know that there's a lot more antibiotic prescribed for respiratory infections than there should be, because most of it is viral. And so we've asked, you know, we had a lot of organizations have funded to have a simple rapid test that could at least distinguish between bacterial and viral infections. And that should be one that parents use at home to test their kids, right? And so all this groundwork that we're doing would really inform, if that test come to be, how we would use it. Because for antimicrobial resistance, we know from the latest Lancet publication that even though the Jim O'Neill report said by the year 2050, there'll be 10 million people who die of AMR-associated infections. Well, in the latest Lancet publication in 2019, there are already 4.95 million people who die of AMR-associated infections. So the crisis is getting worse than we ever thought. And so we need to be doing something about that. And I like to think that this work would be very, very helpful for us to think about the self-tests for AMR that we need. So thank you very much for this opportunity to think through all these. Thank you.
Thank you, Rosanna. Thanks to everyone that has participated today and has actually been fighting against the COVID, bringing so many nice ideas, so much effort, and that is going to leave a very good legacy for the future, for the next generations. And to talk about legacy, we're going to have on April the 7th, another seminar, another webinar. And the idea is really to bring perspectives of testing expansion, then to talk about the WHO and partners through the ACTA diagnostic and the legacy that we are going to leave. Many of us here are taking part in this program. And finally, within the Brazilian environment or scenario, we are going to talk about the last battle, how to keep COVID-19 away. And it's going to be a very nice discussion led by Gonzalo Vecina, the first president of Anvisa. And we are already with several members of the different areas like industry, Anvisa, labs, pharmacies, and healthcare professionals already participating. They have confirmed participation. So it's going to be in the morning in Brazil. So it's going to be easier. And I count on you. And all these discussions that we had today are going to be part of small releases or even papers that we can promote through London School of Hygiene and Tropical Medicine and IDC, through FIND, or for all the ones that can and could use this to leverage the concept of early diagnosis as effective as possible, exactly to bring more health to the people. So thanks a lot. Thank you to the translators. I know we have been giving a lot of hard work to them, and to all of you that have been so far with us. Thank you very much and see you soon. Thank you.
Thank you. Thank you. Bye.